Hello, everyone. Welcome. We're so excited that you're here. Welcome to the first day of the annual 2021 BenU Annual Public Health Conference. On behalf of Benedictine University and our Public Health Student Organization, I welcome all of you. We're so excited that you're here. We have some great presentations and panelists we're going to be engaging with over these next 4 days. And it's going to be great. I'm so excited. I hope you guys are all able to join us for all of the 4 evenings we're going to be having this. So yeah, thank you so much. And as you see on the screen, if you guys have any issues, anything, tech support, anything you need, anybody who is labeled with PHSO after their name will be able to help you. So yeah, you can go ahead and put that into the chat. I know all of you are muted right now, and we please ask that you remain muted throughout the presentations. There will be time for Q&A. There will be time in order to unmute and ask questions, but we ask that you please wait until that time to unmute yourselves to ask any of those questions. In the meantime, you can put it into the chat, but we just want to be respectful of our presenters and our panelists who are going to be presenting tonight. Okay, and then Ellie, if you want to go to the next slide. Awesome. So just to go over the overview of the next 4 days, we will be gathering here 7 to 8:30 Central Time today, tomorrow, Wednesday, and Thursday. Tonight we have the pandemic and beyond. We have 2 awesome presentations today that are going to be sort of focused on the pandemic. We also have a frontline worker panel we're going to be doing tonight. Day 2, we will be focusing on preparing for public health internships and careers. We have an awesome presentation from our Academic and Career Enrichment Center here at the university. And we'll also have alumni joining us tomorrow evening. And then on the 3rd day, Wednesday, we will have 2 sessions. So if you're a current student in our Master of Public Health program, we have an internship information session to help you get familiar with the internship process, finding an internship, and obviously all the internship paperwork and everything that's involved. And then our main session will be the health internship and career opportunities, where we will be joined by several panelists from different organizations and companies that currently have public health positions either open or opportunities that they'll be sharing with us and talking to our attendees about. And on our last day, we are going to be talking about emerging trends in public health. We have 2 awesome presentations on that day as well, where we will be talking about sort of new and upcoming trends in public health and different ways public health is being applied now, now that we're kind of getting into more virtual, digital age, and we're going to be talking about that stuff, so it's going to be really cool. Awesome, and then our agenda for the night will be dropped into the chat shortly, so you can look that over as well. Before we jump into the presentations, I just want to make sure we shout out our leadership team, because they have worked so hard to put this together. They're the reason all this has come together, so I'm really excited. My name is Aishwarya. I am the president of the Public Health Student Organization. We have Christopher Brochek, the vice president, also Mariotti Messenger, who's the vice president. We have Maria, who is our Secretary and Communications Chair, Director of Communications, Iram, Chair of Governance, Treasurers Eleni, and then we have our 2 awesome program specialists, Ashley and Morissette, also. So I'm so excited that we have been able to work together throughout this time. We have put a lot of work these last few months. Really excited that, with everything that we have planned for all of you. So they're an incredible team, and I want to make sure I shout them out. And also, of course, our wonderful advisor, Dr. Krishna Bhagat of Benedictine. She has really been an amazing support for us in helping us put this together. So we're really excited. I'm just really excited about this team. They're just amazing. So yeah. And awesome. So I'm just going to do a quick overview again of today. So we have our first 2 presentations. We have our COVID-19 Vaccine Hesitancy Workshop. It's going to be a great interactive presentation. And then we also have the gaping hole in public health, gaping hole in public policy. So that is also going to be, both of those will be centered around the pandemic. as that's the focus of this evening. And then we will have an awesome frontline worker panel where we will be joined by 4 current frontline workers to talk about some of the changes and things that they've experienced over this pandemic and sort of how that has shaped and changed their jobs. So that's going to be really cool to hear some of those things that they're going to be sharing with us this evening. All right, so that is the overview for the evening. With that, we're going to go ahead and jump right into the first presentation. We have just dropped the agenda into the chat as well, so you guys can take a look at that as well. And with that, I'm going to pass it to Iram to introduce our first presenters.
Hi, guys. I will be introducing the first presentation, which is COVID-19 Vaccine Hesitancy Workshop. And I am honored to introduce the speakers, Dr. Svetozara Zahireva, apologies for the mispronunciation, and Debbie Aceto. Thanks, everyone.
Good evening, everybody. It's a pleasure and an honor to be here and to present. So living in a world characterized by increasingly virulent racism and weakening of civil and human rights, both nationally and globally, is indicative of the increasing need for professionals from public health, social work, and medical areas to understand and address cultural or social differences presented to them by a diverse patient population. And we live in a time where COVID-19 has cost our country more than $16 trillion, which is representative of 90% of the gross domestic product, and has caused 28.5 million cases and the death of more than 510,000 individuals. So according to the 2020 US Census Bureau, our population is estimated at 332 million. At this time, there's only 18 million people fully vaccinated and 42 million with 1 dose, meaning only 5% of the population is fully vaccinated and another 12.8% is in the process. So by having an understanding of the social determinants of health, and with this presentation, we hope to accomplish the following objectives, which is defining vaccine hesitancy, identifying contributing factors and barriers that lead to COVID-19 vaccine hesitancy, understanding the impact of the different models of illness and styles of communication, explaining the value of cultural humility, cross-cultural interviewing, and the different communication approaches in addressing such hesitancy, while also discussing why it's essential for us as public health professionals to help the fight against COVID-19 vaccine hesitancy and recommend ways to do it. So what exactly is vaccine hesitancy? Overall, it is defined as the delay in acceptance or refusal of vaccine despite the availability of vaccination services. It incorporates confidence in healthcare providers that they will be honest about vaccine safety, efficacy, side effects, possible harms, and of course, its benefits. It also incorporates convenience, which is the accessibility and the availability of the vaccine, and lastly, complacency, which is the perceived threat of the disease. According to studies conducted by the American Journal of Infection Control, despite the quick spread and high mortality of the disease, predictors of COVID-19 vaccine uptake intentions were levels of education, insurance coverage, positive attitude, high perceived acceptability, high perceived benefit, high self-efficacy, and low perception of barriers. Similar studies conducted in the 2009 H1N1 pandemic show that negative media and coverage in internet misinformation led to public controversy, and therefore there was a need for public health professionals to aggressively address these myths and misinformation in order to increase the understanding and the acceptance of the vaccine. So what is it that's causing the distrust in the general public, and that it's keeping us from protecting these people and their families by getting vaccinated against COVID-19?
So first, a bit of history. The first vaccine was developed in the early 1800s in England by Edward Jenner, who took lymph from cowpox blisters and injected it in individuals to prevent smallpox. There were valid concerns at the time about this process, including sanitary, safety, and efficacy concerns, in addition to religious and political objections. In 1902, a compulsory vaccination law in Massachusetts was upheld by the Supreme Court. But that did not stop those who opposed vaccines from protesting vaccination. Vaccination for children was made a prerequisite for public school attendance in the United States. But some parents still objected on religious grounds and safety concerns. In the mid-1970s, 36 children supposedly had neurological reactions to the diphtheria, tetanus, pertussis vaccine. And in 1998, British doctor Andrew Wakefield suggested possible relationship between the measles, mumps, rubella vaccine and bowel disease and autism. The research was debunked, but some continued to cite this as support for the anti-vaxxer movement. There has also been a fear of vaccine preservative thimerosal, which has been used by anti-vaxxers. However, thimerosal is no longer used in vaccines. Next slide, please. So there are many contributing factors that play into why an individual might be hesitant to be vaccinated. There's a lack of trust in the government that cuts across racial and ethnic groups. Thus, many may not believe in the government's message regarding the safety and efficacy of the COVID-19 vaccines. There's a fear among undocumented immigrants that having to provide personal information and present oneself for vaccination may lead to deportation. African Americans in particular may resist being vaccinated due to past injustices. The most often cited past public health injustice against African American men is the Tuskegee study, whereby African American men who had contracted syphilis were left untreated in order to study the progression of the disease. COVID-19 has been overly burdensome on minority communities. However, it's been reported that in some surveys, only 18% of African Americans responded that they would definitely get vaccinated for COVID-19. There's also a lack of trust in major pharmaceutical companies, most recently in light of their part in the opioid crisis and perception of profit generation at the expense of public health. Many people do not understand or have not been informed about the rigorous scientific process of vaccine development and testing. In addition, because of the speed of the development of the COVID-19 vaccines, some feel that adequate safety precautions have not been taken. Many people fear side effects from the vaccine, which can vary from a sore arm to anaphylactic shock and the most severe reactions. Some people simply have a fear of injections and will opt not to get the vaccine. Their fear of needles and the fact that vaccines are among the most painful injections cause some to reject the vaccine outright. Many who lack access to health care will be concerned about where they can receive the vaccine and any costs involved in receiving the vaccine. It must be stressed that the vaccine will be offered at no cost for those without insurance. Many of language barriers and cultural differences which make it more likely that they will be resistant to being vaccinated. Special efforts to communicate across cultural barriers will need to be taken to combat vaccine hesitancy in all of these cases. Next slide, please.
So in order to address the public in achieving better health outcomes, it is our duty as public health professionals to have cultural self-awareness. We must be able and aware of our own cultural norms, attitudes, beliefs, and behaviors. By being open to learning from those around us, we can then establish rapport and trusting relationships with the patients. One factor that leads to vaccine hesitancy is the patient's understanding of an illness, which is also known as the health belief model. It helps us understand patients' opinions about vaccines and choose an appropriate communication style during consultations based on a few factors. Those include perceived severity of the disease, a subjective assessment of the susceptibility to the disease, perceived belief of the barriers to behavior change, and the individual characteristics such as demographics, psychosocial, and structural variables. Furthermore, the locus of control also plays an important role in health behavior. In order to change behaviors, there must be a close relationship between individual locus of control, health behavior, sense of control, and self-care. As we can see here, the internal locus of control refers to the traits and characteristics that make people have more control over their lives, such as their attitudes, preparation, efforts, and actions. Meanwhile, the external locus of control includes the beliefs that one's life and experience are influenced by factors outside of your control, such as the environment, other people, and higher power or fate. Thus, it's people's belief of how and why they get sick from COVID-19 that depends on their internal beliefs and cultures, and those factors that influence their health-related decisions. On the next slide, we have a question. We have all heard the saying that vaccines are only as effective as people's willingness to take them. Therefore, seeing the trend of increases in vaccine hesitancy during COVID-19 pandemic is alarming. This poll on the top right was done in the city of Chicago before vaccines became available. And we see people's decision and willingness to take the vaccine drastically drop. So our question is, and if you can input your answers in the chat box, we would appreciate it. What is causing the increase in hesitancy about the COVID-19 vaccine? Is it the lack of trust in the government and fear of big pharma, the rushed clinical trials, as we may have heard, lack of knowledge about the product and its side effects, political involvement, propaganda, fake news, or any combination thereof? Thank you for the participation. I see that everybody is saying option F. So of course, in fact, it's data like this that urges the FDA to come out with a reminder to the public of the fact that science-based decision-making process is what assures vaccine quality, safety, and efficacy for any vaccine. And when asking ourselves the question, what can we do to address vaccine hesitancy? It's crucial to remember there's no one-size-fits-all solution. There are some factors that we can explore, however, which can lead us to the right direction and help us choose a proper approach in these difficult times. So as Dr. Nicole Cook argues, crucial competence and cultural humility compel us to act, to move beyond simply being aware of and sensitive to people's cultural differences. Public health professionals who are culturally competent and practice cultural humility utilize their knowledge to create and implement programs, to design adequate instruction models, and build tools that reflect the different cultures in the communities. These concepts work hand in hand to create equitable and inclusive services. So rather than simply being knowledgeable about cultures, it's important for us to exhibit cultural humility, which is understanding and redressing racial and ethnic imbalances so we can properly develop culturally appropriate programs and interventions. Next slide, please. So based on our cultural humility, we're able to attain positive health outcomes and overcome the widespread vaccine hesitancy encountered in different racial and ethnic groups. According to research, vaccination is one of the most successful public health interventions, but there must be approaches that we take in order to convince people of that and explain it to them in the simplest way possible. Health promotion incorporates actions that increase people's understanding of health and self-actualization. Therefore, utilizing different interview models is another approach that we can help in building rapport with these patients. One of those approaches is the LEARN model for cultural interviews, which incorporates listening to the patient concerns of the illness, explaining in understandable lay terms, acknowledging the differences and similarities in cultural perspectives, recommending diagnostic therapeutic approaches, and negotiating areas of care. Another, which we see on the right here, is the claimant's cultural assessment, which recommends utilizing the questions on this slide to gain an insight of our patients' worldviews, culture, social context, and spirituality. This will allow us to build trusting long-term relationships between providers and patients so we can battle vaccine hesitancy. And this is where culture and healthcare meet. According to the New England Journal of Medicine, social determinants of health have a higher impact on population health than healthcare alone. In order for us to provide culturally sensitive care during patient encounters, we must remember that every encounter is a cross-cultural one. Dr. Sally Arif from the Rush University Medical Center recently conducted a presentation on this topic, and the following message stuck with me. It says that the positive patient outcomes are achievable through the use of proper communication styles. As we can see here, there are two styles of communication, high and low context. For instance, people who prefer high context of communication are greatly influenced by their relationships, family, cultural, and nonverbal elements such as gestures, your tone of voice, or facial expressions. Deciding to change or adapting to change for them is a slow and stable process. This concept is important to remember when choosing proper means of communication with different patients in our work settings so that we can properly and appropriately address their opposition to the COVID-19 vaccine. Next slide, please. And here we have a patient case that was acquired and modified from a ProCE webinar on vaccine uptake in the underserved population. So we have a 45-year-old Indian American female presenting to the pharmacy to pick up her hypertension medication. She's seemingly upset after a conversation at her PCP visit, who suggests that she should get the COVID-19 vaccine to protect herself and her family. The patient refuses to get injected with that poison and get microchipped. If you were in that position and had the opportunity to speak with her, to counsel her, to understand a little bit more about her opinion, what are some approaches you might take to combat the patient's vaccine hesitancy? If you could input your answer in the chat box, or if you'd like to speak up, we would really appreciate it. And in the meantime, I just wanted to say that first and foremost, it's important that we understand why the patient is hesitant. Ask open-ended questions, ask about previous experiences, things she might be afraid of, like Debbie mentioned earlier. Understand her locus of control, like we just talked about, and understand what her perceived susceptibility and seriousness of the disease is. I see an answer in the chat. Have others in her family or social circle received the vaccine? That's a wonderful question. I've personally encountered patients who are greatly affected by that and greatly influenced by others around them. So I think that's a very important question to ask. But it's always important to acknowledge that there is a possibility of experienced side effects. We cannot devalue or discredit anyone's experience or concerns, but what we can do is educate the patients about current studies, science of how the vaccine is made. Addressing questions like what you think will happen if you get affected with the coronavirus, what have other people experienced? Those are all wonderful examples of what we can do to address the patient's hesitancy. If we can go on to the next slide. Debbie?
So how do we combat vaccine misinformation? It's necessary to combat vaccine misinformation on social media platforms in order to reach the greatest number of people. A recent NATO survey indicates that while 51% of those surveyed are likely to get the vaccine, a sizable group of 39% indicated that they're going to wait and see and may not get the vaccine, and another 10% indicated that they do not intend to get the vaccine. It's important, of course, to increase the percentage of people who are willing to get the vaccine by ensuring that people are educated on vaccine safety, efficacy, side effects, and benefits. Local governments and organizations play a major role in providing safe community forums where evidence-based information about the vaccines can be readily distributed. It is important to present information about the vaccine development and testing process, emphasizing that although the vaccine development process was completed in record time, the same steps were followed and the vaccine was well tested for safety and efficacy before being approved for emergency use by the FDA. Research also supports the use of cultural icons such as celebrities, athletes, and respected community leaders in pro-vaccine messaging. These COVID ambassadors are helpful in spreading a positive vaccine message and influencing people to take the vaccine. The messaging should stress protecting family and community. We must be aware of and address cultural differences and language barriers in our communications. We must also be transparent and address and never avoid fears and mistrust among community members by honestly addressing reported adverse actions and long-term effects of the vaccine. Be aware that even if the concern is not supported by the data, the concern is valid to the holder and needs to be addressed in order to provide a comfort level for receiving the vaccine. Next slide, please. So talking about using social media, I have a couple of sample social media messages here. These are two images from the CDC social media toolkit for the flu vaccine. They are both appealing messaging for presenting a many-faceted message in a simple visual package. The first image is a young African-American female first responder presenting a strong image of having been vaccinated against the flu with the hashtag #NoTimeForFlu at the bottom. The second image is a catchy slogan, mask up, lather up, sleeve up, presented for flu vaccination, which can also be used for COVID-19 messaging. Can you think of a simple pro-COVID-19 vaccination message that could be tweeted? Share your proposed tweet in the chat box. Any ideas for a tweet? Okay, I got a couple there. Hashtag COVID vaccinated, hashtag COVID me captain. All right, we're getting some response now. Do your part, I like that. Protect the herd, very good.
I love the say no, but get vaccinated. That's
Yeah. Very good. Thanks for your responses.
And next we have another question. So what is your opinion? Which of the following are adequate approaches to vaccine hesitancy? Describing side effects, addressing patient concerns, making strong recommendations, starting the conversation on vaccines using a presumptive approach, discussing vaccine safety and efficacy, or all of the above, of course, or all of the above except C. So I see a few responses. I also have some B, so let's see, the correct answer here would be G, all of the above. And why C right? It's important to educate the public with up-to-date research-based scientific evidence so they can become aware of the possible outcomes based on whether they choose to get vaccination against this deadly disease. We must be able to convey the message that the vaccines are safe, effective, and accessible, and most of all, can be life-saving for us and for our loved ones. And so what can we do to avoid a situation like this one while ensuring that our patients are aware that the vaccine is not a get out of COVID free card? So research has shown that by investing in social media platforms, public health departments are able to promote conversations, thus directly leading to the desired behavior change through social media campaigning. Social media has a way of reaching targeted audiences and maintaining a consistent voice and presence. So in order to bridge the gap of trust between people of the US and our government, there is a need for public education about vaccines and strengthening of communication methods. The COVID Collaborative Vaccine Attitude Survey concludes that there is a resistance to vaccination in Black communities, and that's based on the lack of trust in the healthcare system, while the Latinx population's hesitancy lies in the lack of access to care. In order to help close these gaps and solve these issues of vaccine hesitancy, we must focus and address the fear, lack of trust, and access to healthcare services in the local, state, and national levels. However, we must never force our opinion on people. We're here to simply provide evidence-based data to help ease their decision-making process. I think that's something very important for all of us to remember. And with this thought, we conclude our presentation for today. We hope you enjoyed and found this session informative. Please feel free to input any questions into the chat box and we will gladly address them.
All right, thank you so much, Debbie and Svetozara. That was such a great presentation, very informative and so relevant to a lot of us working through the times of COVID. And looking for our next presentation, we have Dr. Gina Panozzo and Diana Romero presenting The Gaping Hole in Public Policy.
Good evening, I'm Dr. Gina Panozzo. I'm an assistant professor here at Benedictine University in the Masters of Science in Nursing online program. My colleague who could not be with us tonight, but I will share a recording of him discussing the background of this topic, is Dr. Stephen Almada. He is an independent health psychologist and epidemiologist at the Health and Sports Institute of Chicago. We strongly believe in interprofessional collaboration and merging the health disciplines, which is why we've been working together. He's the author of numerous journal articles. He has a passion to address obesity. Actually, that's his goal in life, is just to get people moving and get them to exercise and eat healthier, make better lifestyle choices. He is the author of the book Exercise, Life, and Love, and the originator of the Stronger Than Stress program and the Mindfulness Eating Training program. He's actually with clients tonight working on that program. So just to give you a little bit of background, and then I'll play a recording from him. We are working on trying to disseminate this topic and bring more attention to it. We are technically in multiple pandemics right now. The COVID-19 pandemic, but also the obesity pandemic. And unfortunately, this pandemic is affecting children at a very young age. And the world has rapidly responded to the COVID-19 pandemic and come up with various policies and solutions within a year. But the obesity pandemic continues to fester and grow over decades. We're strongly proposing, just as the COVID-19 pandemic has had multiple solutions, that the obesity pandemic has some type of policy enforced, which we're proposing a mandated exercise program in schools that's standardized throughout, not just in a school here and there and in certain countries, but just consistently. So if I can get my audio to share, I will play Dr. Stephen Almada.
Spoken policy of inaction. Whether it is a plague, war, famine, or some other catastrophe, when the lives and livelihood of millions of people are threatened, it is incumbent upon society and its leaders to come together and take whatever actions are necessary to protect lives. This is the integrative approach that embodies the One Health concept, first introduced in 2004 and adopted by the World Health Organization. For most countries, the One Health concept characterizes the response to the COVID-19 pandemic, as recommendations made by public health officials became quarantine, social distancing, and masking policies mandated by political leaders and complied with by citizens. Scientists worked to develop and test vaccines, and the economy assured the production and widespread distribution of these vaccines, and now people are lining up to get vaccinated. From the One Health perspective, if just one of the parties involved failed to do their part, the entire fight against COVID-19 would be at best compromised, if not a disaster, especially if the failure was at the policy mandating level. It is precisely 50 years of failure among policymakers that has allowed inactivity and obesity to become one of the longest pandemics in the history of humanity. Morbidity and disability from COVID-19, as bad as it is, pales in comparison to the 4 million inactivity, obesity-related deaths that occur every year and account for 2.8% and 3.8% respectively of global disability-adjusted life years. Underlying the difference between the response to COVID-19 and inactivity obesity pandemics are three policies: the neoliberal economic policies of laissez-faire and indifference, and the political policy of inaction. Dr. Panazzo and I propose the childhood inactivity obesity pandemics are products of the conceptual conflict between One Health social policies and the economic policies of stakeholders in the food and beverage industries. Central to this conflict is the excessive imbalance of power that impede implementation of One Health integrative policies while advancing the divisive policies of the food and beverage industry. The conflict makes the childhood inactivity and obesity pandemic a policy problem that requires a government-mandated One Health social policy to resolve them. The World Health Organization recognizes childhood inactivity and obesity as pandemics. Therefore, a One Health policy should include a mandate for implementing physical activity programs in elementary schools, as well as a mandated ban on the advertisements of high salt, sugar, and fat processed foods to children. The physical activity mandate is a logical starting point, given inactivity is a gateway to obesity and lifestyle diseases. Ironically, in the face of overwhelming empirical evidence to support a physical activity mandate, and governments acknowledging the seriousness of these childhood pandemics, politicians have failed to fulfill their social responsibility. Siding instead with the food and beverage industry, policymakers assert inactivity and obesity are personal and parental responsibility problems. In so doing, politicians implement an unspoken policy of inaction, abdicating their governing duties to the persuasive power of $4.2 billion that the food and beverage industry spend on advertising to children. Not many parents have that kind of economic power to invest in influencing their children. And no public health media campaigns promoting regular exercise and sound nutrition are going to influence children like the 3,000 advertisements they see every day, most of which are for high salt, sugar, and fat foods. The childhood inactivity and obesity pandemics are the price society pays when the persuasive power of $4.2 billion is unleashed by political inaction and allowed to take possession of children's minds. Under pressure from public health organizations, the food and beverage industry have repeatedly promised to reduce high salt, sugar, and fat food advertisements to children via self-regulation. However, the promise has yet to be fulfilled and seems unlikely, given that it would defy the unspoken policy of indifference inherent to the neoliberal economic imperative of maximizing gains that are in one's self-interest. Invoking Newton's laws, we argue that the only way economic power can be regulated is by another power, and that power must be the political power that represents the will of society and its citizens. The United Nations and World Health Organization recognize health as a human right. The right to be healthy is the right to feel whole and alive. In this regard, the physical activity mandate is particularly urgent. The food and beverage industry process foods to target the pleasure centers of the brain. Though the brain does not discriminate pleasure, be it from junk foods, crack cocaine, or exercise, the body does. The food and beverage industry make children feel whole and alive without being healthy. It is a classical conditioning process that can easily lead to a lifetime of addiction to the superficial pleasures of high salt, sugar, and fat foods. In contrast, the good feelings of exercise are increasingly being recognized as the best reason to exercise and as potent therapeutic tools in the treatment of depression and anxiety disorders. The density of the exercise experience is critical to the healthy development of children, and it positively affects every cell in the body, and thus warrants a physical activity mandate in elementary schools. As public health specialists, all of us must work together to pressure and demand political leaders to use their power to fulfill their social responsibility and protect and promote the health and well-being of children and all citizens. Thank you for your time.
Okay, so after hearing from Dr. Stephen Almada, one of our members is working on the breakout rooms right now. But as we go into those rooms, I would like you to chat among other attendees and your peers these two questions. Should any disease be allowed to be spread? And does it matter if the disease contagion is bacteria, virus, or a way of life? So first of all, consider what a disease is. Is obesity a disease, just as COVID-19 is a disease? Type 2 diabetes, for example, or any other disease that you can think of. And when you think of spreading, can a disease spread through droplets or through airborne, or also just through societal norms, cultural norms, and a way of living life? So we will go into the breakout rooms for about 4 minutes and discuss these two questions, and then we'll return for the presentation. Okay, I think we are all back. So I hope you had time to at least think about these two questions, and we will revisit them at the end of my presentation. So just to compare these two pandemics that we're in, COVID-19 and obesity, if we think about the prevalence, does it matter in terms of where we put all of our attention and focus? So COVID-19, there has been roughly, and these statistics obviously change a little bit every day, but 117 million cases in over a year, which affected 1.5% of the world's population. But if we look at those who are overweight and obese, globally, that has affected 39% of the world population among adults and 16% among children. Does mortality matter? So once again, COVID-19, 2.5 million deaths over the course of more than a year. Inactivity contributes to 3.2 million deaths per year. And this is globally. Those who are overweight and obese contribute to 4 million deaths per year. And then in terms of just the global death rate, In 2017, it was 56 million deaths. Cause is just overall, so any cause, just those who have died globally is 56 million. So what is inactivity? The World Health Organization notes that 31% of individuals 15 years or older are physically inactive, which basically means they do not obtain the recommended level of physical activity per day and mostly live a sedentary lifestyle. Typically, if a person is inactive by the age of 15, they have been inactive prior to that. And that's why we're addressing obesity among children, because it tends to start when they're younger, and then it just snowballs into their adolescence and early adulthood, and then later in adulthood as well. So now let's talk about the differences in terms of how we've responded to COVID-19 versus obesity and the disparity. So within a year, regarding COVID-19, we've had all types of mandates, mask mandates. The economy has changed significantly. There's been massive production of PPE and ventilators. We've had rapid production and distribution of vaccines through multiple pharmaceutical industry companies, and currently clinical trials are underway for children. And we've also had laws passed to help the health and economic well-being of businesses and individuals. How have we responded to obesity? Well, there's continues to be lack of government mandates for standardized exercise programs in school. We continue to see the massive expansion of the fast food industry. In my breakout room, we talked about how there's a Starbucks on every corner, and how large companies such as McDonald's hire marketers and psychologists to get into the minds of 2-year-olds so they know what a Happy Meal is, and they see the sign and they cry for it and ask their parents for it. We continue to see encouragement to be sedentary, engage in large amounts of visual stimulation through the internet, social media, video games, and TV, and the growth of surgical procedures and pharmacology as a quick fix. Unfortunately, the more people that become obese, the more different industries profit. So the One Health perspective, Dr. Stephen Almada talked about this in his recording, and I will speak to it a little bit further. So if we broaden our perspective and we think about our COVID-19, inactivity, and obesity, one disease, if we think of health just as a big umbrella term. So the One Health concept is an ecological integrative approach to developing social policies, and it's actually been used and modified since the late 1800s. Dr. Stephen Almada notified us that it has been more recently adopted and modified in 2004, but it's actually been around since the 1800s. This concept brings together multiple stakeholders committed to understanding how human activities, lifestyles, and behaviors become the causes and the consequences of disease dynamics and ecosystems. So the One Health concept views animals, humans, and the environment as one. So they all relate, and they all should be considered and treated equally. And if we think about infectious diseases, roughly 75% of those are zoonotic. So that's why we do need to think of One Health approach as the environment, humans, and animals, and how we interconnect. The environment has greatly shaped the food industry, disease, and obesity, just as it's contributed to the spread of pathogens such as the coronavirus. And this way of thinking needs to go beyond obesity and other pandemics and actually focus on root causes. Given inactivity is a gateway to obesity and non-communicable disease, one way to address this massive problem is proposing a physical activity mandate in all schools globally as a logical starting point for crafting this One Health policy. So the One Health policy has 5 different criteria. And although many countries have operational physical activity and nutrition policies, they have not been effective in fighting the childhood obesity pandemic, and it's partially due to government mandates. So we propose taking this concept or model and using it as a premise to develop a mandate among schools. If we look at the first criteria, it raises concerns about the risk-benefit paradox of exercise. And risk versus benefit, there's very small risk in terms of cardiac death or sudden death related to exercise when we look at the benefits of it. The second criterion would be met if the burden of inactivity is substantial in at least a subset of the population. So given 81% of adolescents do not meet the World Health Organization recommendations on physical activity, the burden will likely increase over time, and evidence supports regular exercise for the prevention and treatment of obesity and non-communicable diseases. The third and fourth criteria relate to prevention and protection. And higher levels of physical activity early in life are inversely associated with the development of childhood obesity. Evidence also supports physical activity as an effective treatment for obesity. A cost-effective analysis of strategies to increase childhood physical activity would not only increase levels among them and their implementation, depending on the intervention, it would prevent roughly 2,500 to 110,000 cases of childhood obesity. And the fifth criterion concerns the accrual of benefits from a physical activity mandate. A mandate would make exercise available and affordable to every child without imposing an economic or logistic burden on children, parents, guardians, or society as a whole. Over a 10-year period, these programs have the potential to prevent 110,000 cases of childhood obesity and save society up to $185 million. So we need the public's attention. As we know, policy makes and breaks a pandemic. Pandemics are socially constructed by social institutions that have a stake in the health and well-being of a society. Global consciousness needs the wisdom of scientific experts and public health policymakers to collaborate and provide guidelines for preventing and stopping a pandemic. And a pandemic is fully legitimized when the power of governments join with public health specialists to mandate implementation of their policies and initiate social action to prevent, treat, and eradicate the rapidly spreading deadly agent. So if we go back to our questions that were posed in the breakout sessions, I would open either the chat or just if you want to unmute. What do you think about these questions? And after hearing the presentation and perhaps your discussion in the breakout room, do you think any differently about what a pandemic is or what disease is and how we've had such a disparity in terms of attention between the two pandemics? Okay, so I see one comment, having COVID can kill other people, having obesity cannot. Is it not an important differentiator when evaluating intervention? So that, I think that's it's an interesting point. Obesity can kill, as we have seen, and has killed more people than coronavirus. It's just spread in a different way. It's spread through psychology, through a way of life, through marketing, through access. But it still can spread and kill because it becomes a lifestyle and a way of thinking. But it may not be spread through the air necessarily, droplet, airborne type of.
I'm sorry, that was my question. I just want to clarify. Obviously being obese can be lethal for the person who is obese, but it's not lethal for, people around them, unlike COVID or the flu or, pick your XYZ infectious bacteria or virus. Like, isn't that a distinction that we should be thinking about?
Anyone else? It's a good point. Let me stop share just so I can see if there are other questions or people that want to chime in. So any thoughts on obesity in terms of it being contagious? I think that's kind of that point of discussion.
I think to connect the two, and hi, Chris here,
Okay.
connecting the two, what the point I believe that's being made. So for example, obesity in terms it's not contagious in terms of person to person, but how society targets the youth, that is what you were saying, and how they increase obesity by such as things like McDonald's charting 2-year-olds, but also, for example, populations. I believe I was reading something in terms of West Virginia as the highest rate of diabetes at 36% of adults over the age of 18 have diabetes in West Virginia. That's the type of contagious you're talking about on a populational level.
Right, and cultural, and the rate that it is contagious is much higher than what we've seen with other pandemics that have been based on a virus or bacteria.
All right, thank you.
Thank you. I see another comment. Yes, culturally contagious, absolutely.
I
But
also
does that
wanted to
change
add,
our intervention?
sorry.
Oh, go ahead. Is that Maria or Caitlin?
I'll let Caitlin go first.
Okay. Caitlin, you're muted if you wanted to say something.
Sorry, I was saying, doesn't that change our intervention? It is a different thing when you can actually get other people sick immediately than, you know, a sort of more just as real, but more ephemeral and slower kind of cultural diffusion.
And I think the term sick it's hard to describe, because if someone goes in and they're tested, we immediately have that statistic, but people are sick and dying from obesity, but it may not be as measurable as quickly. So once again, it's a perspective and kind of looking at it from a lens of a long-term type of slow death versus perhaps more of an immediate type of contagion. Maria?
Can I say?
Oh, go ahead. Is that Ambrose? Go ahead.
Yes. Can I? Also, obesity. If you look at the way it's spread, to me, when McDonald's advertise their Happy Meal, and they know that some of those foods are toxic to young children, and they know that it's affecting the psyche of the children, to know that my mommy get it for me, and they'll throw a tantrum, and the mother will get that food for them. They know, and some of those other industry that advertise those kind of food. To me, it is spread by the airway, because those people are deliberately attacking young children, and not only they're attacking them physically but mentally, and that could be very, very dangerous.
Right, and that's what Dr. Stephen Almada was alluding to, in terms of how this has become a huge societal problem. I mean, just go to the grocery store and look at the types of foods that consume 90% of the aisles, and look at what's on every corner when you drive the next time, and how the government continues to allow all of that because it's a money-making industry. But then we have another type of pandemic that we can actually test and measure, and we can see that it's contagious rapidly. And we have just drastic amount of intervention and money thrown at another pandemic while obesity is ignored. Maria, go ahead. I think you were next.
No worries. I was just going to add on to like the culturally contagious points, is that also there have been studies that have shown that obesity, it can spread with who you're hanging out with too. They have shown that if you are hanging out with other obese individuals who tend to eat a lot, it could actually cause you to also to socialize, to eat a lot too. And so that is another way that it maybe could be spread too, like from one individual to another. It's not like COVID-19 where it's respiratory, but it could be just because of the fact that you're socializing, and you may actually lose time when you're socializing. We all do, and you eat more, parties and so forth. So that's something that also could, you know, maybe be viewed more too, or maybe revisited when looking at like maybe the culturally contagion looking at it as like a culturally contagion.
Thank you, Maria.
All right, and actually, just last two questions, and then we do have to transition to the.
Sure. So should we take just Noel and then Mariatti, and then we'll end?
Yes, thank you so much.
Go ahead, Noel.
Can you hear me?
Yes.
Okay. So I wanted to go back and touch on something that Ambrose said that was very interesting. Growing up in a society where, you know, when you went out to eat was a treat. Growing up, I should say, in a generation where when we would go out to eat, it was a treat. It wasn't the norm. You know, and as Ambrose stated, the kids crying and screaming that they want something and, you know, wanting mommy and daddy to buy it for them. What is wrong with our parents these days just saying no and, you know, helping their children by saying no and making sure that their children understand that that's not something that is a normal everyday food product, you know? What's wrong with our fruits and vegetables being cheaper than our junk food? It shouldn't be that way. We should be spending less money on the right things and more money on the things that are not feeding our bodies properly.
Yeah, one of many variables, right, that contributes to this large
Absolutely
problem. Yeah, good, very good point. And then we'll end with Mariatti's comment.
Hi, Mariatti. I just wanted to mention, I want to go back to Caitlin's question, and I want to say that I totally understand where she's coming from in terms of the types of interventions dealing with the difference between obesity and let's say COVID-19, for example. I think there is a difference in terms of interventions by because, okay, I want to say like COVID-19 has been killing people at a much faster rate than obesity. And therefore, people tend to think short term. So they respond much more quicker if you get sick right away and you die right away. So that's why there's been much more attention and much more money being piled in over to COVID-19 interventions as to compared to obesity interventions, right? Obesity, it does take longer. It's a long-term kind of mindset when you have to think about all these different interventions. And most people do not really think about long-term ideas or what will happen in the future that long. Like, oh, like when you eat something, like when you eat like a hamburger at McDonald's, you're not going to think about like 10 years from now, what's going to happen to me if I keep eating this like every now and then, every week, what's going to happen to me? I'm just thinking about, I need to feed my family. I need to eat now, and I don't have the money. So, but no one's going to think about what's going to happen to them 10 years from now. As opposed to right now, people are thinking about, oh my gosh, I need to wear my mask. I can't be next to someone right now. I don't want to get COVID-19. I might die, things like that. So it is very interesting, the difference between two different diseases here. You have the non-communicable diseases and the communicable diseases. So yeah, I just wanted to mention that.
Thank you so much, Mariatti. We have an interesting perspective. Okay, well, that will wrap up my presentation. Thank you so much for all of the contributions and the comments in the chat.
All right. Thank you all so much, Gina and Diana. That was such a great presentation, informative, and everyone that joined in participation of conversation, fantastic job. On to our next topic, which will be the Frontline Worker panel. We have Noelle Dethridge, Stephanie White, Ashley Dyke, and Julie Schallhorn. And first, we'll start off with Noelle Dethridge.
Thank you, Chris. So I kind of did a slide from the point of view of being a leader to the front line during the pandemic. So you can go ahead and switch to the next slide. So during the beginning of the pandemic, I work in a healthcare field, and within the food and nutrition department, I'm a patient services manager. My role as a patient services manager is essentially to manage, lead, jump in and help out the entire patient services team, which consists of people that serve food to patients, consists of people that build trays and put the food on the trays and then bring it to the floors, and then some other folks that are around the kitchen. So we have about a team of 66 employees just under me. And so during the pandemic, it was very difficult because these folks are not clinically trained. So when we're trying to explain things to them, new isolation requirements, new protocols, changes in their meal delivery, methods, it was a lot of stuff that was very new to them. And being that we're in the food and nutrition department, it's a lot of very entry level positions. So the folks that are working there are not as highly educated as some of the clinical people up on the floor. With that being said, it was a lot of moving parts, and my team was not really privy to the clinical base where they knew what isolations needed to be handled and things of that nature. So what I did was reached out to the clinical leaders and the infection prevention team, and I got a meeting together and asked them what, as a food team, we needed to do in order to keep not just my staff safe, but I wanted to make sure that the patients were still being safe, as well as getting the meal that is what they needed. But remembering that this is, a meal in a hospital is something that is only the thing that is positive in these folks' day. And so making sure that they still got the greatest meal that they could get and safely for them and for our clinical staff and for our staff was one of the largest tasks that we had. As most of you know, COVID changed on a daily basis during the first 6 months of it. So it was a lot of getting in there, helping them get acclimated with the different changes daily, having huddles to make sure that they could understand everything that we're doing. We brought down the infectious disease director. We brought down the infection prevention team just to kind of talk things through with them. So really supporting the team and their concerns was one of the biggest tasks. And, still to today, we do this every day. I check in with my folks every day and make sure that they are doing well. Next slide, please. So what do we do day to day? So what I do day to day, I kind of went through this slide a little bit before. I work at Central DuPage Hospital in Winfield. We have 396 beds. We serve about 260 meals a day times 3. So we have about 260 patients on average, and they get 3 meals a day. Plus we also do kind of like a late night snack type meal for those that come in a little bit later. So one of the biggest roles that I did have, like I had mentioned earlier, was educating and leading my team safely as COVID-19 ebbed and flowed through the last 12 months. Next slide, please. And so essentially at the end of the day, I have had the greatest opportunity to work with some people that I may never have gotten to work with, being that I work in the food and nutrition department. Built some very, very well-rounded relationships with clinical team, clinical staff members, even administrative leaders that otherwise would probably have never even known who I was. And they come to me for my opinion on a lot of stuff. And it's really nice to know that, there is no barrier to who is a leader, depending on how much status you have or whatnot. We all came together and we all brought in our disciplinary approaches, and we had to work together, and we had to make sure that everybody was safe. And navigating the unknown without experience would have made things very difficult for us, not only us, but for our staff who, you know, they're just coming into work every day and with fear that if they come into work, they might leave with COVID, or they might have COVID, not know, and bring it to somebody else. So there's a lot of just fear in the entire time during the pandemic, and just keeping my patients up to date and supporting them, you know, giving them the shoulder to cry on because they're stressed out because they don't know what's going on. You know, just letting them know that I'm here for them and I'm here to help them, and whatever they needed to do that day, you know, if it was taking a 5-minute break, we have what we call renewal rooms. And so there's some amazing doctors volunteered to give money to get some massage chairs and put some yoga mats and just do a real nice like meditation type room, a couple different areas in the hospital. And so I will say, go take 5 minutes, go to the renewal room, go sit, go be in peace, go, you know, get a massage for a couple minutes, do what you need to do, take a break, you know, sit down, have something to drink, whatever I can do to help them feel like they're not just coming to work because they feel like they don't have a choice. And while doing that, making them feel comfortable coming to work and, you know, supporting them and letting them know like, hey, you're safe. And if you're here, I'm here and I'm going to be here with you, and whatever you need, we'll make sure that we take it on. And then another part of my job is to, you know, as patient services manager, is to make sure that all the patients are taken care of by the food and nutrition department, as well as ensuring that I speak with patients daily, you know, and I try to get to between, you know, 30 and 40 patients a day. With COVID being at the height of COVID, we didn't have that opportunity. So I needed to incorporate something where I could still talk to the patients, get, you know, make sure that they're still doing okay, ensure that they're still getting warm meals. And then, you know, seeing what we could still do, what kind of opportunities we have to be better. So I incorporated telerounding, which essentially is just what I would do if I had to take their diet order, is calling them and saying, hi, you know, my name is Noelle. I'm going to just see how your meal service has been going since you've been here. Oh, I see that you're on the specific diet. You know, do you have enough options? If not, like, what are some things that you eat at home that we could possibly help you out with? And depending on their diets, you know, it would have been some easier options, being a little bit more lenient if it was allowed by the dietitians and the doctors. So some stuff like that, but just making sure that they were still okay, giving them that thought that, you know, just because you have COVID, you're isolated, nobody can come and see you, doesn't mean that we don't care about you. So those are some really great things that we were able to incorporate during the pandemic. And it's changed a lot of what I do now too, when I come to work every day and I see my associates and I just come in and say, how you doing? What's going on? How's your weekend? Or how was your day? Or, you know, more so than I had before. So, you know, that, and then always making sure that I'm checking in on our patients. So it's been a lot of change, but not all of it has been negative. It's been a lot of good stuff. A lot of good changes, a lot of positive changes for not only, I think, for myself, but for my entire department. So it's been really nice. Can you change the slide, please? Oh, that is my last slide. Okay, I couldn't remember if I had one more on there or not. So as far as the pandemic changing work, I mean, I still would continue to do what I do every single day. It was just a matter of learning how to do it differently and giving courage and supporting my team, as well as the other multidisciplinary teams that I worked with. So it was a lot of different, a lot of education, a lot of learning. So thank you.
Thank you so much, Noelle, for that presentation. We very much appreciate it, and thank you for being a frontline worker. Our next presenter is going to be Stephanie White.
Hi all, good evening. My name is Stephanie White. I am here in North Carolina. I work for Levine Cancer Institute and Atrium Health. And so my title professionally is a cancer program development specialist, but that's a lot to say. So we typically just say we're an advocate. We're also known as patient navigators. And most of us have public health backgrounds or social work. Typically what my job looked like before COVID, and this is actually really cool because this is the job that or the role that I interned with. And so she offered me a job before graduation in 2019, and I've been with them ever since. And so prior to that, we would be out in the community, interacting at health fairs with different facilities such as like Butterball, Chewy, different corporations that would want us to come in and talk about cancer awareness and promote education, and then another aspect of our role is just to go into the communities, which are typically underserved. So about 90% of our populations that we meet with are uninsured. They are well below the poverty threshold here in North Carolina. And as you can see in the corner down there, we have 2 roving units, which we just call our buses or our mobile lung units, which we take out into about 18 counties. So prior to COVID, we were only in 15 counties, and we are thankful and grateful enough to have expanded into 3 additional counties, which we cover. In all of our counties, we serve them. We provide mammograms, we provide lung cancer screenings, prostate screenings. We also provide colorectal screenings through FIT testing. And all of these are made possible through grants, fundraisers, which took the largest hit for us this year. Typically, we get anywhere per program, per county, about $60,000 to $100,000 from fundraising initiatives. We actually raised $12,000 this year for all 18 counties. And so we have had to be very creative. Another thing that's changed for us is that when COVID first hit in March, we were not allowed to go into the community at all. And so for the first 3 months, we were doing point of entry screenings. And I do remember sitting there, and a doctor that I had left from my previous role as a clinical trials coordinator, he goes, "Yeah, you're really putting that MPH to use, huh? It was worth it." And I said, yes, it was actually, because sometimes it's not about what you do, it's about how you do it. And I think the one thing that I've learned in all of my public health education and experiences, we pivot, we change to what the patient needs or our community's needs. And so you may go in as a cancer program development specialist, but however, you are really there for the patient, and sometimes you just need to be an advocate. And so through that, we had to figure out how we could still work with our patients and meet them where they were at. And we found one of the largest areas was food insecurity. So we found a grant that allowed us to provide boxed food deliveries to our patients. So there were active cancer patients, and then just our unserved and underserved communities. We provided them each patient got about $100 worth of boxed foods every 2 weeks. We did that for about 3 months, and then the system recognized what we did, and they picked it up for themselves and funded it even more. And that program is still running today. And then in July, we were able to go back out on the road with our mobile lung screening units. And so the white one at the top is the first one that we have. And then the second one at the bottom is our new one that we introduced in July. And as you can see on the white one, it's popped out a little bit. And so that's where the scanner, where the guy over to the right is laying on. And that happens on both of the units. What we've realized is that even though COVID is going on, primary and preventative screenings does not stop. We still have to make sure we're providing these screenings at free. We're not charging our patients at all. So we have to make sure that patients are still educated, getting their screenings, and knowing that it is safe and it is okay to come into the hospital, see your doctor for these types of screenings. So we're just still promoting education and awareness through being less in the community than we usually are. Thank you.
Thank you so much, Stephanie. Thank you for all our hard work. That is some of the coolest things I've heard so far. It's really awesome.
Thank you.
Jua, our next frontline panelist will be Ashley Dyke from Benedictine University.
Hi, everyone. Thank you for joining us for the first day of the conference. My name is Ashley. I'm a program specialist for the Public Health Student Organization. Professionally, I'm a telehealth ambassador and medical scribe through Scribe America for UCSF Health Outpatient Clinics. I scribe for ophthalmology 5 days a week and pediatric dermatology once a week. So as a medical scribe, my primary function is to assist the doctor with documentation and electronic medical records, freeing up time to give maximum attention to patients during their visit. I prepare medical records for visits, pre-charting, updating history, and sometimes presenting this history to the doctor. So during the visit, I'll update the chart with any changes made, inputting exam information, history, diagnoses, assessment, the plan, and billing. I also prepare orders for medications, diagnostic testing, and surgery. Of course, all under the instruction of the doctor. They have the final say, and then send out any outgoing messages for other doctors and instructions to the patient for their after visit summary. So adapting, to the pandemic has been a challenge. Our in-person clinics were converted to hybrid telehealth to give us maximum safety to work from home during a time of greatest risk of infection and a minimal available personal protective equipment. So initially there was an increase in telehealth visits for audio and video patient encounters, but this ended up being more of a way to triage patients from the safety of their homes to find out which patients really needed to be seen in person. As you can imagine, it's very difficult to see inside a person's eye over the video, which is the primary way that ophthalmologists, especially surgeons, diagnose and decide proper treatment for patients and whether they need more emergent care or are ready for surgery. So most of the patients seen in ophthalmology clinic are surgical candidates or have already had surgery and need regular follow-up to prevent complications that might require, more surgery or even lead to blindness. So ophthalmology, switched to what I would call a more hybrid model of telehealth, where the medical scribes connected through Zoom from the comfort of their homes, that's me, while the physician and the patient were mostly, face-to-face in clinic. And the clinic volume was decreased to accommodate the safety of in-person visits and social distancing while still adhering to the COVID safety precautions and the checks. Of course, patients had more anxiety to come into clinic, especially since most patients are in the eldest age of the population and most at risk for complications if they are infected by the coronavirus. And this is reasonable, of course, during a pandemic. So one of the doctors that I work with would conduct the visit in a separate room over Zoom and only enter the patient room for the actual eye exam, and then immediately return to the empty room next door to discuss any treatment options and management over video, since it was really difficult to adhere to the social distancing in the patient rooms. So the pandemic has also created major job insecurity. There were around 100 of us in July, and UCSF made a decision to permanently transition to telehealth scribes. But unfortunately, it means that the current scribes, including myself, would not be eligible for transitioning into this new role since we are in California. And so I'm still able to scribe for the same physicians I've been scribing for the last 2 years, but I'm starting to train out-of-state telehealth scribes to replace me. And as you can imagine, this is very challenging over Zoom, as I've never met the trainees, and we can't really talk a lot during the clinic. And that's under the assumption that technology and the internet are working that day. So I'm very grateful for the time I spent in the clinic connecting with medical staff and patients, but it can be constricting and depersonalized over audio, since no longer seeing people face to face and unable to use visual cues and body language to conduct the job. So I do rely heavily on the provider to tell me, which patient they're seeing before every visit, because otherwise I have no idea of knowing and nobody else to ask. And many patients have inquired if Ashley, that's me, is the new Alexa, thinking we're the newest generation of medical AI. And I just want to say thank you for being with us tonight. And the next speaker is actually one of the physicians that I scribe for.
Thank you so much, Ashley. The next speaker is Dr. Julia Schallhorn, who is Allie's boss, or Ashley's boss. Thank you.
Hi, everybody. Thank you so much for having me. And I'd just like to say this has been a really, really wonderful and educational event. So really nice job to the organizers. Yeah, I'm fortunate enough to work with Ashley. I am at UCSF and I'm an associate professor of cornea. I'm also our associate residency program director. And the pandemic was a very, very interesting time. So just to give you some background on both of those, you know, I see patients and I treat patients for diseases of the cornea and external eye. And I also am responsible for the education of our residents, which are all surgeons in training to become, you know, eye physicians. I love both those roles. They're really, really wonderful. But as when the pandemic unfolded, it presented a lot of challenges, both from the patient care perspective, as well as from the residency education perspective. So in the early days of the pandemic, our department's initial response was to really shut down, except to all but the most urgent patients. You know, we are a tertiary referral center at UCSF, so we see patients with blinding eye conditions, and we wanted to be open to take care of people who were at risk of going blind. But at the same time, you know, most people with ophthalmologic issues are elderly. You know, we didn't want to bring people in that were at risk of contracting, you know, COVID from other people in the waiting room or potentially from us, you know, needlessly. So, you know, the first response was basically to really restrict patient visits. We rescheduled as much as we possibly could to telehealth, although it is, as Ashley mentioned, really difficult to see patients via telehealth with ophthalmologic concerns. And we also set up kind of like a drive-through, you know, eye pressure check clinic, because one of the most pressing things for many patients is that their eye pressure is elevated. So we devised a way to do that safely. That was done by one of our fellows, actually, and one of my colleagues, Jeremy Seitzman. After that, the next concern for me was twofold. You know, number one, how do we maintain our ability to deliver eye care at any time of the day with our residents? And number two, how do we maintain the educational experience of our residents? So we divided our residents initially into teams where we had, you know, team A for Monday, team B for Tuesday, team C for Wednesday. And so that to try and ensure that they didn't overlap with one another, because at first we really didn't know how contagious things were going to be. And then also, you know, we immediately pivoted to doing as much as we possibly could educationally remote. And because our clinic volumes had dropped, that meant adding in additional lectures to our residents. You know, we recruited, you know, before this, we'd never done anything via Zoom ever, you know, really with our residency class. And suddenly, you know, within a week, 100% of our educational activities were and still are, you know, via Zoom. It was really a remarkable turn. I think everybody kind of experienced that. But, you know, we were able to band together with other residency training programs in the Bay Area, you know, Stanford, California Pacific Medical Center, UC Davis, to develop kind of a pan-campus educational curriculum so that the residents had educational opportunities available to them from other institutions as well. And then within our own program, since the residents did have a lot of other time because they were really only in the hospital 1 day a week during the first, you know, 6 to 8 weeks of the pandemic, developed a research training curriculum very, very, very rapidly. You know, I got them all onto data camp. They all learned R, which was amazing with a lot of hard work. And then they all took some statistics courses as well that were available through, you know, edX or Coursera. And we also did a epidemiology, which you of course are all familiar with, learning module to really make use of their time. And that actually went pretty well and was pretty productive. You know, following that, we started to phase in, you know, once we got a little bit more information about how, you know, the relative dangers of COVID and the control measures with the masks and things like that. You know, we started to phase back into clinical life because as you can imagine, there's only so much we can do over telehealth. So we had a lot of a lot of patients that we really needed to see, and kind of started increasing that. And, from the patient perspective, at first, it was very jittery for everybody. It was a lot of anxiety, and, those first patients coming back in to see us in, May, June, were just incredibly anxious. And I was super anxious too. But as soon as, with time, we really started, kind of becoming more routine. And now it's just a routine thing. You do your, UCSF set up this big COVID screening protocol, which all these questions that you have to answer every day you come in, the patients have to do it too. And, we do our screens, and now we see patients with our masks on, and they have their masks on. So it's kind of a new paradigm shift, but, really presented a lot of challenges initially, a lot of, new workflows that we really hadn't thought about, and really shifted us to doing really a new way of education for our residents. And some of that is actually for the better. So I think Zoom lectures and the ability to connect over long distances like we are right now is not something that's going to go away soon. So thank you again very, very much for having me, and really wonderful meeting.
Thank you so much, Dr. Schallhorn. That was such a great presentation. As for our Q&A portion of the panelists, we've covered most of them. So I think the most important question to ask our panelists through working through COVID, what are some strategies that you have used to deal with the stress of being a frontline worker during this pandemic? What are some things that help you to deal with mental health and the emotional toll of the pandemic? And for that question, we'll start off with Stephanie.
I think one of the tools that I've picked up is just to shut down, really. And my director makes sure we shut down. We literally will just turn off our email notifications. Working from home on the days when we're not screening, it's very easy to stay logged in until, you get it done, or you're like, I'm just gonna knock this one more thing off my list for tomorrow. But then it never knocks off. Another way that I've tried to kind of debrief daily is just like at least 30 minutes of yoga. And I get to do that with one of my friends because she's in Atlanta, and we do it over Zoom. So Zoom has changed the scope of everything we do now. And then lastly, I would say just enjoying more hobbies and activities, whether it be like crafting or just something artsy that I can just take my mind off of the day-to-day work stresses.
Fantastic. Thank you so much. How about you, Ashley?
So for me, to keep my mental health during COVID-19, I do work from home, and I can't say that I step outside every day. So to keep my mental health, I make sure that I exercise in my house every day. If anyone has tried using the Beachbody online program, it's pretty good. And I also love to cook, so I make sure that I'm cooking healthy meals from home, and I'm just trying different things. Yeah, that's just one of my passions.
Thanks so much for your input, Ashley. And lastly, Dr. Schallhorn, what are your best strategies for keeping the stress down?
Yeah, I mean, it's definitely been very stressful, and probably the biggest anxiety issue for me, at least initially, was, the worry about, bringing this home to, to my family. My oldest daughter has cystic fibrosis. And so I was really, really worried about, potentially getting her sick. And, meditation really, really helped. And then just following best practices, that had been recommended, making sure you gel your hands, I wore an N95 mask, and, changing my clothes as soon as I got home. And then just, making sure when I did have time to, do some, gratitude practices. Which I wasn't really actually that worried. To be fair, honestly, it was incredibly stressful for me. And then UCSF had a frontline provider like call line that you call on if you were feeling very, very anxious. And so I got connected with a psychologist actually, and who, we discussed some relaxation techniques and meditation, and then like a gratitude practice, just taking count of like things in your life that are going well, things in your life that are thankful for, that you can focus on, rather than kind of like perseverating on, you know, the stress of the day and the negative emotions of the day was really, really helpful for me. And I've actually just incorporated that into my routine and then also into my family's routine, that we take some time every evening to just think about the day and then think about what we're grateful for during the day. And that really has helped a lot.
Thank you so much, Dr. Shellhorn. That was a great response. Okay, well, that concludes our panel. If Eleni could exit the screen, we are now going to open up questions for the audience to ask our panelists or anyone who has presented this evening.
If you guys don't want to come off of mute to ask your questions, definitely, you know, you can put it into the chat or send it to us, and we'll be happy to pass it along to the panelists or any of the presenters to get responses for. So feel free to send us questions after the session as well.
All right, so we'll go ahead and close everything up. Just a couple reminders. So don't forget, if you haven't already, join us for tomorrow for day 2 as we talk about public health internships and the careers. And also follow us on the Benedictine PHSO social media. And in the chat box, we have inserted all the different social media handles for every one of PHSO. So go ahead and follow us on that. And then for those students that are here, if you are interested in joining PHSO, feel free to give us, shoot us an email at our Gmail account over here. And then lastly, feel free to complete this evaluation for today's presentation. The link is already up on there, and we'll also go ahead and send out a link to in a later email. And recording of this will be available after the conference. Thank you, everyone. I know we have went a little over time, but it was really good conversations that we all had today and really great. And thank you to all the presenters that had presented today. Looking forward to seeing you guys all again here, same time tomorrow. Thank you. Have a good night.